The following podcast is part of a certified educational activity titled Mastering the Evidence and Establishing Best Practices for Making Well-Informed Precision Decisions in EGFR-Mutated Non-Small Cell Lung Cancer. Access the entire activity and complete the post-test at peerview.com/ZAF860. Downloadable slides and practice aids are also available.
Hi there, welcome to this PeerView live program on mastering the evidence and establishing best practices for making well-informed decisions for patients with EGFR-mutated non-small cell lung cancer. My name is Natasha Lael from the Princess Margaret Cancer Center and the University of Toronto, and I'm delighted to be joined by my co-chair.
I'm Joshua Sabari, Thoracic Medical Oncology at NYU Langone Health, Perlmutter Cancer Center in New York, and Natasha, really looking forward to a great discussion today.
Absolutely. Thank you so much for joining us. So our goals for today are to increase your knowledge of the evidence and guidelines supporting the use of different treatments in this setting, and also to help equip you with some of the skills that you'll need to develop individualized treatment plans for our patients with EGFR-mutated advanced non-small cell lung cancer. So the guidelines today are very complex, especially in the first line. These are from the NCCN, and you can see that for patients with common sensitizing mutations, we now have three preferred options: osimertinib, amivantamab plus lazertinib, and osimertinib plus chemotherapy. And tonight we're going to talk a little bit more about the evidence outlining all of these. So let's start with a case. This is a 61-year-old lady. She's a lifetime non-smoker, presents with a cough, shortness of breath, and fatigue for the past 3 months. She has an opacity in the left upper lobe, and on subsequent workup on PET has a 3-centimeter left lung nodule, enlarged mediastinal nodes, and multiple FDG-avid hepatic lesions and bone lesions. On brain MRI, she has 4 small lesions, all less than a centimeter, consistent with metastatic disease and without edema. Lung FNA shows TTF1 positive adenocarcinoma, and on molecular testing, we see that it's an exon 21 L858R alteration, PD-L1 negative, and this patient comes to your clinic to discuss first-line treatment options.
Thank you, Natasha. I agree. It's an exciting time with multiple different regimens available in the frontline setting. And I want to go back to the basics. So here's the FLORA trial. This is the original trial that led to the approval of a third-generation EGFR TKI, where we studied osimertinib versus gefitinib and erlotinib, being first-generation EGFR TKI. And what we see here is an 18.9-month improvement in PFS, or 18.9-month median PFS, with an improvement of about 8 months or so. It's important to note that we improved intracranial penetration versus the first-generation EGFR TKI. And we also saw improvement in a lot of the EGFR-mediated toxicity. So osimertinib was a cleaner EGFR inhibitor, less, sort of rash, less diarrhea generally, and overall less paronychia as well. When we look at the overall survival that was published a few years ago now, median overall survival for osimertinib, 38.6 months, versus the first-generation EGFR inhibitors of 31.8 months. So truly a real benefit for our patients in clinical practice. One thing to note, though, is when you look at some of the subsets of patients with exon 21, which you just mentioned, Natasha, those patients didn't seem to benefit as much. Median PFS there, about 14.4 months. When you look at exon 19 deletion, median about 22 months or so. Now, what about the first-line progression-free survival in the most updated combination study? And why are we doing combination trials? We're doing combination trials because we want to improve outcome for patients. So this is the FLORA-2 trial. The FLORA-2 trial is a randomized study of osimertinib plus chemotherapy versus chemotherapy alone. And the goal here is to see if the addition of chemotherapy up front could potentially eradicate persister cell populations, allowing patients to benefit from therapy longer, hopefully living longer. And it's important to note that this study, the primary endpoint was looking at investigator-assessed progression-free survival. We did not routinely monitor the CNS in this patient population Up front, patients had MRI brain, but only if they had brain metastasis were we following subsequently with MRI. And what we see here in the PFS is an impressive improvement for osimertinib plus chemotherapy, median 25.5 months versus osimertinib alone of 16.7. So this is a clinically meaningful benefit, and we saw this across both exon 19 deletion as well as the more difficult to treat exon 21, L858R. We have an interim analysis, a second interim analysis for overall survival trending positive with a hazard ratio of 0.75, but still immature. Clearly, when we use combination strategies, there is potentially more toxicity. We do see more myelosuppression, neutropenia, thrombocytopenia with the addition of chemotherapy, and we do see slightly increased rates of chemotherapy-mediated toxicities, nausea, anorexia, potentially some increased rash, as well as diarrhea in this patient population as well. Now, what about the impact of tumor burden in these patient population? And Natasha, going back to the case, you mentioned the patient has a high burden of disease, liver mets, brain metastases, bone metastases. How do patients do with, sort of large burden of disease? So here we're looking at the CNS in this patient population. So if you look on the left, in patients with CNS metastases, osimertinib plus chemotherapy does appear to rescue this patient population. Median progression-free survival, 24.9 months versus osimertinib monotherapy at about 14 months. If you look at the group without CNS metastases, by and large, those patients are doing better, but still a benefit for osimertinib plus chemo over osimertinib alone. And here, just looking at the waterfall plots, osimertinib plus chemotherapy did show a very high proportion of complete responses in the CNS. And we know that osimertinib largely is a brain-penetrant therapy. For me, the question really is durability in this population. Now, moving to the third study, this is the Mariposa trial. It's another combination strategy here with amivantamab, an EGFR and MET bispecific, in combination with lazertinib, a third-generation EGFR TKI. Again, this is a large international randomized trial. Here we're looking at 3 arms: amivantamab plus lazertinib, the treatment arm, versus osimertinib, the control arm. And there was a third arm of lazertinib, which to look at contribution of components. So here what we're looking at is the progression-free survival of amivantamab versus osimertinib, and an impressive improvement in progression-free survival for ami and laz, 23.7-month median progression-free survival versus osimertinib at 16.6 months. It's important to note on this trial, we did do routine CNS imaging, so we truly have a very good sense of the intracranial progression-free survival, which we'll discuss. We did see an earlier interim analysis for median overall survival that was trending positive, and we'll show you the final overall survival momentarily. But at what cost? We do see some more toxicities, primarily cutaneous toxicities, paronychia, rash. There is the infusion-related reaction, as well as an increased risk of venous thromboembolism. And looking forward to hear from you, Dr. Leal, on sort of management strategies in this patient population. When we look at those patients with or without brain metastasis in the amivantamab and lazertinib cohort, you do see a significant improvement for activity in those patients with a history of brain metastasis. Median progression-free survival for amivantamab and lazertinib, 18.3 months versus osimertinib alone at 13 months. And if you look at those patients without a history of brain metastasis, this patient population just by and large does better, but clearly also a benefit here for amivantamab and lazertinib, median 27.5 months versus osimertinib alone of 19.9 months. And I think this is really the take home here. What is the overall survival? And when we think about a therapeutic option for patients, we want them to do well, but we want them to live longer and have good quality of life. So we saw the updated overall survival at ELCC. And here in the amivantamab and lazertinib, median overall survival was not reached. And if you look at osimertinib alone, 36.7 months. using a statistical analysis, if the data continues to trend out the way that it is looking here, there would be a minimum of 12 months improvement in overall survival for amivantamab and lazertinib over osimertinib alone, hazard ratio here of 0.75. Now, coming back to the CNS activity, remember on the Mariposa trial, we were routinely monitoring CNS. So we do have, we're able to report out a true intracranial progression-free survival. And at the 3-year landmark, 36% of patients were intracranial free of progression, 36% receiving Ami-Laz, versus osimertinib at 18%. Hazard ratio here of 0.79. And when we look at the duration of response, you do see an improved duration of response intracranially for amivantamab and lazertinib at 35.7 months versus osimertinib alone of about 30 months. So I want to throw it back to you, Natasha, to discuss our case and to have a discussion on what would you do in your clinical practice.
Great. Thank you so much, Dr. Sabari. That was a wonderful review of the evidence. So this patient, as you pointed out, she's got extensive disease, high disease burden. She does have brain metastases with small lesions. She has an L858R alteration. What treatment would you recommend at your center?
First off, she's young. She has a high risk mutation and she has high burden of disease, as you mentioned. So for me, I'm thinking combination strategies up front. But what's most important is what are the patient's wishes and the patient's goals. So when I sit down with a newly diagnosed patient with EGFR mutation, I do look at the sort of different characteristics. But what's most important to me is to actually present the data and discuss the data with the patient. And looking at her case and if she's willing to sort of take on the additional toxicity of amivantamab and lazertinib, that would be my recommendation in this scenario, primarily because she's fit. She has an L858R mutation as well as diffuse systemic burden of disease. Dr. Lear, what would you do in clinical practice here, and what does that discussion look like for you in this patient population?
Thanks so much. I agree. We do spend a lot of time talking to patients. I always find it very interesting that I assume most patients are only going to want osimertinib, and so often that's how we'll start. But very quickly, within a week, they've gone online, they've done some research, and they come back and they want to discuss combination regimens. But I agree. This is a well lady. She's in her early 60s. She does have extensive disease. She does have that L858R mutation, and I agree with you. I would favor combination therapies, but again, some patients, they're either so overwhelmed or they just really want to avoid chemotherapy or IV therapy. Patients have many reasons for wanting different things, and so I think the discussion will really guide it. It is very interesting, when osimertinib became our standard, even though it was perhaps less, not as efficacious, the difference or the improvement wasn't as good for our patients with exon 19 deletion mutations. I think especially based on, the fact that it wasn't any worse and the fact that, it was so well tolerated, we really all switched en masse and really didn't think about the mutation type anymore. So it's interesting that this is now something that comes up in discussion again. How about for you? Do you routinely, if they've got an L858R, do you routinely recommend a combination? And also, when we think about the two combinations, we now have one study that's a little bit further ahead of the other. Does the fact that we've seen survival data that's statistically significant for one of the trials change your conversation with patients?
Yeah, I think it definitely does. And similar to your practice, I do discuss all three regimens. And, you'd be surprised. A lot of patients do want single agent osimertinib. They want an oral therapy. They want to continue on with their life. And I think, that's appropriate in some patients, particularly patients who are older, more frail. But I'm actually looking for reasons not to give combination strategies now. And I really do discuss the FLAURA2 regimen in detail. I explain chemotherapy. I explain what the pemetrexed maintenance looks like. And we know historically chemotherapy is largely well tolerated in patients. But for me, it's a standard of care in the second line setting. And as you mentioned, a lot of patients don't want chemotherapy, or they're asking us for chemotherapy-free regimens. That being said, with amivantamab and lazertinib, yes, there is a high tox burden, and we'll talk a lot about it today. But, with the overall survival data, I think that really is an important point, because we don't truly have full survival data back on the FLAURA2 regimen. And to show patients, the two curves, and, patients say, I want to be on that curve where I'm living longer. And look, if FLAURA2 does have positive overall survival, we'll have to discuss that with patients in clinical practice. So I think having that updated data is important for our patients. With regards to mutation status, I do think of L858R slightly differently. I also look at co-mutation quite a bit in this patient population. But again, it really does come down to patient preference and sort of what do they want in their clinical practice. Natasha, what if it's an older patient, more frail patient? Have you ever used combination strategies? Or what if you have an older, frail patient who wants a combination strategy? Are you talking them out of it?
It's a great question. And, I think it's so important to separate age from performance status and frailty, that tolerability issue. We all meet patients who are a phenomenal 90 and perhaps are better than some of our patients who are in their 40s or 60s just because of disease burden or comorbidities. And so, in my clinic, I really work very hard to pull those two things apart. If a patient is very interested and we think that they can tolerate it, then we try. I'm always mindful of the fact that osimertinib by itself is still a fabulous treatment option for patients. And so if patients start and they realize, taking on a little too much here, or they get admitted, or they have severe toxicity, can always drop the combination. Similarly with amivantamab and lazertinib, you can always pull back on the drugs or dose reduce. And so I think that's very important to remember. But again, I agree with you. Selection is so important. In those survival curves that we've seen so far, interim for FLAURA2 and the wonderful final survival data for Mariposa, initially, patients don't all do equally well, right? So we do need to be very thoughtful about selecting patients, those that will get through initial toxicity and do well longer term to really enjoy that benefit of combinations and live longer. So my poor performance status patients with a lot of comorbidities where I'm worried about combination therapy, frail patients rather than older patients, these are patients where, and often we all agree, osimertinib is a fabulous option by itself. And then for my patients that do want to escalate, where I am a little nervous, always remembering that we can pull back. And I think that's so important. And I agree with you. The question is really more the profile of the patient where you don't need to intensify rather than, all of those patients upwards of 80% where you probably are going to see some benefit from intensification. So, lung only, good performance status, no brain involvement. And we're going to talk more about some of these other exciting factors that have emerged, such as co-alterations. And we're gonna put you on the spot again, Dr. Sabari, to give us some more data about that.
I think age and, performance status are not, equal. I agree. If someone has, sort of great performance status and is 80, they may do better than a patient who's 65 without, great performance status. But what about CNS? Because, I see a lot of my patients, 40% plus, have brain metastasis. The case we're talking about here, patient has 4 small brain lesions. Dr. Leo, does that affect how you think about your therapy selection? Look, osimertinib is one of the better CNS penetrant drugs, and I'm quite impressed that we're able to build upon that with FLAURA2 and Mariposa.
Thanks. It's absolutely true. It is such a great option. And we finally trained our radiation oncology colleagues and surgical colleagues to call us before they intervene with local therapy so we can do it together as a team. And what was very interesting about both of the trials that you discussed was that the actual response rates were similar, whether it was single agent osimertinib or the combinations. But it was really that duration of response. And in FLAURA2 in particular, we saw the depth of response that was really different. And so, I think those data are so compelling that now when our patients do present with brain metastases, I think we really are obliged to discuss combination therapy with these patients, just because we do know that they will do better long-term with intensified therapy. Having said that, there will still be patients that, where single agent osimertinib is the right answer with some, little SRS here and there, or local therapy as required. And so definitely CNS involvement for me is a real trigger to make sure that we take that extra time to discuss intensified therapy. There are, of course, other considerations beyond efficacy, in particular adverse events, prophylaxis, managing side effects, and access to treatment. What's really great about FLORA-2 is, these are well-known quantities. We're very familiar with osimertinib and toxicity management, very familiar with chemotherapy, with pemetrexed and carboplatin, and it really is just additive. There doesn't seem to be any synergistic or unexpected toxicity beyond 1+1 adding, or 1+2 adding all of these drugs together. And as we saw in FLORA-2, we really just saw incremental hematologic toxicity from the chemotherapy addition. So myelosuppression, obviously you need to be a little bit more mindful of thrombocytopenia, but it really was myelosuppression that we saw an increase in, and the other toxicities were about what we would expect from either agent. And interestingly, when we looked at patients that stopped treatment with FLORA-2, it was actually most commonly that maintenance pemetrexed, which even without osimertinib or in our patients with non-oncogene addicted lung cancer, the ability to keep up maintenance long term is really what limits us from dose delivery. So very well tolerated, and in particular, myelosuppression being the big standout in terms of incremental toxicity. With Mariposa, again, very, very exciting. Amivantamab is a known quantity intravenously, and so most of what we saw was related to EGFR inhibition and MET inhibition, and of course the infusion-related reactions. The first hour of cycle 1, day 1, we saw this in 2/3. This is very much what we can see, and this is very easy to manage. We did see more skin toxicity when we added amivantamab and lazertinib together compared to osimertinib, really because we're doubling down on the EGFR receptor. Patients were on treatment longer, so of course we saw more toxicity, but otherwise it was very consistent with what we already knew. About 20% of patients, 21%, did have some rash prophylaxis at the beginning of study. Not very many were on anticoagulation, only 5%, and we did see thromboembolic events occurring in 40% of patients in the amivantamab and lazertinib arm, which was something that we didn't expect, compared to 11% in the osimertinib arm, and has really led to the recommendations for anticoagulant prophylaxis, particularly in the first 4 months. And I'll talk a little bit more about that. So in that first 4-month period, skin toxicity, as you'd expect, rash and paronychia, some stomatitis, generally low grade, and then this incidence of thromboembolic events, as well as other skin toxicities and itching. After that first 4 months, though, really paronychia, much less common, but sort of being the most persistent event or AE that requires management for our patients. And once we're past a year, again, a much lower incidence. So VTE, not more than expected at baseline in this particular population, beyond that 4-month period. So most things occur early, and with longer term use, we really don't seem to see new or emergent concerning safety signals. So really long-term treatment in our patients is manageable. So far, we've really seen some great prophylactic approaches, particularly managing the EGFR side effects of this combined approach. And so in the Cocoon study, we looked at antibiotic prophylaxis, topical prophylaxis beyond the first 12 weeks, and then also some prophylaxis for paronychia. And the Cocoon regimen, and these data were presented by Dr. Girard at the European Lung Cancer Congress, we were able to decrease the risk of dermatologic toxicity by 50%, so a 2-fold reduction in significant adverse events that were grade 2 or higher. It's very meaningful for our patients. Also at ASCO last year, it's now published, and World Lung, but we heard about the SKIP-IRR regimen. We're using prophylactic dexamethasone and IV amivantamab. We were able to markedly reduce the incidence of infusion-related reactions, and that's just with a very simple regimen. Dexamethasone, 8 milligrams twice a day, starting 2 days before, the day before, and an hour before treatment. And then we were able to go ahead with IV amivantamab, a 3-fold reduction from 2/3 of patients to 22%. And again, none of these were severe. So I think really things that we can do today for IV amivantamab, so we don't need to wait for new formulations. Also, prophylactic anticoagulation, a marked reduction in venous thromboembolic events from 20% to 11%, about what you would expect to see in this population of patients with advanced disease. So clearly, with prophylaxis, we can markedly improve the journey for our patients and decrease toxicity. With the cocoon regimen, with the prophylactic oral antibiotics and then topical, we saw a 2/3 reduction in skin toxicity. And with scalp toxicity, these are the pictures we often see when patients have challenges, but a 70% reduction in severe skin toxicity in terms of scalp adverse events. Paronychia, a 25% reduction in the incidence of severe paronychia. We still have some room to move here. We need to improve our prophylactic strategies, but clearly we really improve things across the board for our patients with skin toxicity. Also, what does this mean in terms of patients being able to continue versus having to stop? We do see a marked improvement when we use prophylaxis in terms of 50% reduction in patients needing to interrupt the dose, more than 50%, so a 19% proportion of patients needing to dose reduce if we don't prophylax versus 7% if we do, and markedly fewer patients needing to discontinue, not only for skin toxicity, but overall due to any adverse event, from 19% if we don't prophylax to 11% if we do. So really, really important that we learn how to use this and start to integrate this into our daily practice today. Something that's near and dear to my heart, the Paloma program using subcutaneous amivantamab and lazertinib. This is now nearing approval in Europe. It's been recommended already by the CHMP, but in particular, we were really able to show that subcutaneous amivantamab had similar outcomes clinically and similar pharmacokinetics to intravenous amivantamab when we added lazertinib, and also we had longer duration of response and unexpectedly better overall survival. We also saw that patients had a marked reduction in infusion-related reactions, 13% compared to 66%, and also a lower rate of venous thromboembolic events, and of course faster and easier for patients, 5 minutes compared to longer treatment. However, having said that, intravenous amivantamab is available here and now, and some of these other prophylactic strategies that we've talked about really make this much more manageable in the clinic. With all these great data about preventing side effects, Dr. Sabari, what are you actually using in your day-to-day practice now?
I think first off, it's critical to discuss the toxicities with patients, but also to sort of educate them on, sort of how can we mitigate these. So particularly for the Mariposa trial, for the first day, the infusion-related reaction we know is quite common. It's improved significantly now that I'm using dexamethasone 8 milligrams 2 days before, a day before, and then the day of with intravenous dexamethasone. We've seen sort of a threefold reduction in this infusion-related reaction. But more importantly is telling the patient that you may have this reaction, educating your staff, and having them notify us if there's any issues. And then I really stop the therapy that day and hold the dose and bring them in for cycle 1, day 2 to complete the dose. The other thing I talk a lot about is the cutaneous toxicity, and the cocoon regimen really gives us a very clear sort of guideline, a roadmap of what we need to do. And we know that prophylaxis, prevention here really pays off in this patient population. So, I am starting oral antibiotics. I use doxycycline, and I want to do that for the first 12 weeks. Thereafter, I move usually to a topical, clindamycin. I educate patients on the importance of, emollients, skin creams that contain ceramide. I also tell patients to stay out of the sun and to wear, suntan sort of, or sunscreen, not the opposite of suntan, but we want them to use sunscreen in this population. And then paronychia can really become an issue in patients. So, using chlorhexidine rinses can be very helpful at mitigating some of the nail bed type issues in this patient population. But again, early intervention is critical. And we know that, 2 weeks, 4 weeks in, most patients are going to have some rash generally acneiform of the chin and the nasolabial fold. And we want to get on that, quickly. We don't want that to turn into infection. And I think, most of my issues that I've had with amivantamab have been, sort of the cutaneous, sort of dermatitis, that pustular eruption, where sometimes we do need to dose hold or dose reduce, but preventing that and sort of holding early when needed allows patients to be on therapy more durably. One case that comes to my mind is I had a woman on therapy for over 2.5 years who was dealing with the cutaneous skin tox, but she over time would let us know early when she felt that she was having an eruption or ulceration in the skin. We would hold, we would treat aggressively with antibiotics, and then resume, obviously, with our help of our dermatologist. So, this is a feasible sort of regimen, but you do need to put in the effort and the time up front. Dr. Leah, what are you recommending in this setting as prophylaxis?
Thanks. So we are now trying to follow the cocoon regimen. So instead of doxycycline, I use a lot of minocycline. We actually demonstrated a long time ago now, Dr. Barb Malosky from Vancouver led the Pan-Canadian rash trial where we showed that these drugs do decrease the incidence of rash. And so, we use this routinely for the first 12 weeks, and then we switch to topical. We do the chlorhexidine soaks. I will say, clearly that needs to be improved. We need to do more to protect patients' fingers and toes. And so sometimes, we'll use vinegar. We have a very close network where we have a dermatologist who specifically does toes and fingers. So that's his area of expertise. And he's really, we have a number of experts now that have really grown with us through the amivantamab program. So that's been a great resource for us. And really activating that nurse-led care, that early intervention, treat a grade 2 like a grade 3, really kind of accelerating the support and management of patients so that things don't get neglected, things don't get left behind. One of the other challenges, of course, with anticoagulation prophylaxis, in our clinic, we just used the first 4 months because that was really when the increased risk of adverse events was seen. It's interesting, though, we haven't seen that in the other trials, right? We didn't see it in Chrysalis. We didn't see it in Chrysalis 2. We didn't see it, to the same extent in Paloma 3, even in the IV arm. And so, you do wonder, this was sort of a bit of a standout. And so, it's our hope that we'll learn more about this and how to prophylaxis more easily. What are you folks doing in New York for that?
For VTE prophylaxis, I agree. It wasn't something we commonly saw with single agent or even in combination with chemotherapy, for example, but clearly with the addition of lazertinib to amivantamab, there's a 3-fold increase in VTE. And I think it's something that needs to be dealt with and sort of discussed with the patient up front. So we're starting prophylactic doses of anticoagulation, not full doses of anticoagulation, prophylactic. And, I am seeing a sort of, very low rate of VTE, similar to sort of the data you had, presented in the Paloma 3 study, where, with EGFR mutant patients, we know there's a 10% rate VTE in this patient population, and they need to be monitored closely. So if someone has new lower extremity edema or swelling or new onset chest pain or shortness of breath, think DVT, think PE, it's critical. And in that case, I would then treat with a therapeutic dose anticoagulation in this patient population. One question that I commonly get is, what about a patient who has CNS metastases? Natasha, does that concern you? Is that patient not a candidate for the Mariposa regimen? Are you not using prophylactic anticoagulation in patients with brain metastases?
Thanks. So we do use it. I mean, antibiotic prophylaxis is very safe. You always worry, could someone develop hemorrhage? Really, in my experience, that's not been a challenge. Even in the old days when we used VEGF inhibitors, we were able to do this safely despite the presence of brain metastases. So we do use the prophylactic anticoagulation. Of course, patients with brain mets are the ones who benefit from intensification. So we don't change our practice. How about for you?
If a patient doesn't have any hemorrhagic component of the, CNS met, I totally agree with you. I think the rates of, bleeding is extremely low. And remember, we're treating these patients with effective therapies, amivantamab and lazertinib, and we actually, see very low rates of CNS bleeds. In a patient with a large tumor, a hemorrhagic component, I would talk to my neuro-oncologist, neuroradiologist before, sort of feeling comfortable with starting anticoagulation, but generally has not been an issue in my clinical practice.
Thanks. And of course, the other issue is, right, it's prophylaxis. If there's a compelling reason why you or the patient is concerned about it, right, then again, it's just information. As long as the patient's informed and they understand the risks, and we go ahead and we're just that much more mindful about picking up anything early. That's great. Any other comments you'd like to make about toxicity and toxicity management in your practice and prophylaxis?
I think the key thing, again, is education, getting your team involved, getting family members involved. This is not a drug we're giving for 2 months, 3 months. Hopefully patients are on these therapies for long periods of time. So it's really the long haul and how we think about sort of, achieving, durable response with good quality of life. One thing that I oftentimes talk to patients about is it's not a failure to dose reduce. It's not a failure to dose hold. If we can continue to give therapy over time, allowing patients to recover from toxicities. And we've done this many a times with chemotherapy. I think amivantamab here and lazertinib is no different. So, thinking about dose hold, dose reduction makes sense if the patient needs it. And I think will allow patients to remain on therapy longer and allowing them to have durable responses.
Great. Thank you so much. So let's move on to our second case. The considerations, when someone doesn't have brain metastases, but, a non-smoker, this time a 58-year-old man who has a cough, again, very similar lung disease, mediastinal nodes, bone disease, very common, as we know, in patients with EGFR mutant lung cancer, but this time doesn't have brain metastases. Again, lung adenocarcinoma. And this time, in addition to the EGFR mutation, we have co-mutations. So we do see an alteration in TP53 or perhaps another tumor suppressor gene, high PD-L1. They come to you.
Thank you, Natasha. So we had talked about some clinical characteristics earlier, but here we're talking about, some biologic characteristics of the tumor. And, one of those is co-mutations. What other alterations are identified in the tumor? And, generally we've thought and known for years that if patients have more mutations in their tumor, they may not respond as well to targeted therapy. There may be sort of opportunities for potential resistance mechanisms. So what is the relevance of TP53? TP53 is the guardian of the genome. It's a tumor suppressor gene, and we see it, altered or lost in about 50% of people with EGFR mutation. So when we look at the rates of TP53 mutation in first-line combination therapy EGFR mutant patients, what is the outcome in this patient population? So here you can see that, co-mutations can be used as a prognostic biomarker, right? If someone has, P53 mutation as well as RB1, another tumor suppressor gene, or PTEN loss, that can portend very poor prognosis. In many retrospective series, if you look at these Kaplan-Meier curves here, you can see that co-mutation in TP53 and other tumor suppressor genes are associated with worse outcomes to early generation TKI, where if you look at a TP53 mutant and a TSG mutant population, median progression-free survival is only 8 months, versus if you look at the wild type population, far higher in that 13-month range. So when we look at the Mariposa data, Mariposa study again being amivantamab and lazertinib, and we look at the progression-free survival by whether patients had TP53 co-mutations, it's actually quite impressive that if a patient has a TP53 co-mutation, we know that's a higher risk population for osimertinib, median progression-free survival 12.9 months, with the addition of lazertinib to amivantamab, median progression-free survival here in the 18-month range. Clearly in those patients who are TP53 wild type in the curve on the bottom, you see that patients generally are doing far better. Median progression-free survival for ami-laz 22 months versus osimertinib 20 months. So this is something that I do think about in my clinical practice. Now, what about FLAURA2? FLAURA2, as you remember, is osimertinib plus chemotherapy versus chemotherapy alone. And again, we know that P53 alterations may be prognostic for progression-free survival benefit with OSI plus platinum pemetrexed over osimertinib alone. And again, looking at the TP53 wild type population, they do far better than if you look at the patients who have TP53 alterations. What's interesting about OSI plus chemo versus OSI mono is really no significant difference in median PFS here, 27.6 months for OSI plus chemo versus 27.6 for osimertinib monotherapy. Now, moving on to other sort of genomic characteristics or biomarkers, what is the value of monitoring circulating tumor DNA in EGFR-mutated non-small cell lung cancer? And the rationale here being that if someone has a large burden of systemic disease, and we had talked about this earlier, bone metastases, liver metastasis, for example, they may be shedding more tumor DNA, and we can identify tumor DNA in the peripheral circulation and the plasma. So we know that patients who have large volume or detectable ctDNA in the plasma may do worse than patients with lower volume disease who are not shedding tumor DNA. And when you look at the Mariposa trial and you look at progression-free survival by detectable baseline ctDNA, so you do a plasma next-generation sequencing study upfront on patients, if you identify an EGFR clone in the peripheral circulation, median progression-free survival for Ami-Laz is 20.3 months versus osimertinib alone at about 15 months, telling us that there is a true benefit for patients who are ctDNA positive. Those are higher risk patients in my clinical practice. What about those without detectable ctDNA at baseline? There, the patients by and large do far better, but still a benefit in amivantamab plus lazertinib at 27.7 months versus osimertinib alone at about 22 months. So not only upfront may ctDNA be important, but what about after treatment? We can assess whether we clear ctDNA in the peripheral circulation. So we looked at that on the Mariposa trial, and we looked at rates of ctDNA clearance by 9 weeks, repeating a plasma NGS test to identify whether we could find an EGFR clone in the peripheral circulation. And what we found was quite impressive. In those patients who did not clear the EGFR clone, they tend to do worse in general. If you're treated with osimertinib alone, median progression-free survival in those who did not clear their EGFR ctDNA clone was about 9 months versus about 16 and a half months for amivantamab and lazertinib. In those patients who do clear their EGFR ctDNA, and this is far more common, we see this in 80 to 85% of our patient population, there, amivantamab and lazertinib had a median progression-free survival of 24 months versus osimertinib at about 16.5 months. So what is the value of monitoring ctDNA? And Natasha, I look forward to the discussion with you about whether you're doing this in your practice or not. But in the FLORA-2 trial, very similar data, right? In those patients who had detected ctDNA, if you look at osimertinib alone, median PFS as low as 14 months. And if you look at osimertinib and chemo, the addition of chemo to osimertinib, median PFS in that 25-month range. And clearly, if you don't have ctDNA detected, those patients just by and large do far better. And I was impressed to see that there was really no significant difference with the addition of osi chemo at 33 months versus osimertinib alone at 30 months for those who cleared or had no ctDNA detected up front. So let's jump back into the case here, and I wanted to turn it to you, Natasha. What would you use in your first-line treatment in this specific patient? Remember, a young patient, 58 years old, L858R exon 21 has a co-mutation here in P53. Interestingly, CNS imaging without any evidence of brain metastasis. What would you do?
Thanks so much. This patient, he has so many high-risk features. He's younger. It sounds like he's well enough to tolerate combination therapy. I would definitely talk about escalating therapy for this patient. And I do agree with you. The data that you've shown are very compelling. We know that patients with concurrent TP53 alterations or other co-alterations, they do have a worse outcome, a worse prognosis. And so they too fall into that group where intensification makes a difference. I think TP53 is easy. It's often measured. Things like MET, I think, remain very intriguing. We saw some beautiful data from Benjamin Besse from the Chrysalis 2 study. You were part of that as well, that suggested that, there might be this real standout benefit in patients with some sort of MET-driven signaling using amivantamab plus lazertinib, but these aren't data that we could take forward. This was not part of the Mariposa study. We don't use this in clinical practice. It's not yet ready to help us select patients. So currently we don't use MET status for that. And in fairness, they are all subgroups. So we really put the whole thing into perspective. So if a patient just has very small volume disease, but they happen to have a TP53 alteration, we have much more of a discussion. Perhaps co-alteration as a standalone is perhaps not as impactful as everything else that this patient has. Love ctDNA, as you know. I always think a liquid biopsy comes in handy. And I agree with everything that you raised, that, that prognostic value at the beginning. If I find the EGFR alteration in plasma, I tell my patient, well, the great news is we found it earlier. The difficult news is this perhaps is a little bit more meaningful for you in these data looking at intensification are perhaps a bit more relevant to you. In my patients that are plasma negative, they do have a better prognosis. In Mariposa and to some extent in Flora 2, everyone seems to benefit from combination therapy, but perhaps in those that have that better prognosis that do not have detectable ctDNA, maybe this is a group where maybe we can de-escalate. A great trial, of course, Josh, you guys are participating in this, led by Dr. Helena Yu, where patients get induction TKI, and then they're randomized based on clearance or no clearance to either intensify or not. I think that will help us learn whether or not we can. Right now, it probably doesn't help, and even if you clear your ctDNA, that benefit from intensification still seems to be there. So we're not using it yet. I am trying to see if patients that don't have ctDNA in their plasma might be a group that we could de-escalate in. But again, I think we need the trial. So not doing it to drive decision-making routinely. How about in New York? Are you using it to drive decisions?
I think it's something that I talk to patients about, and I use it as a prognostic, but we're not using it to guide therapy right now outside of clinical trial realm. So, we do have the Shedder trial open, led by Helena Yu, where we randomize patients if they are ctDNA positive 4 weeks after the initiation of therapy, randomizing them to receive a Flora-2 regimen of osimertinib plus chemo versus osimertinib alone. And I think that's where the future is moving, right? Where we see true benefit for patients with combination strategies, but maybe there's that patient who might benefit from osimertinib alone, right? We all have patients 4 years, 5 years out on single agent osimertinib who may even have an L858R mutation. So how do we select the right patients? And I think as we continue to collect data, this is going to be really important. I think molecular status in the plasma is going to be critical. What about, Natasha, if you see ctDNA positivity, at 9 weeks per the study or 4 weeks, does that make you add therapy, or are you still waiting for further data? Meaning escalation versus de-escalation.
Thanks. And again, it's a great point. So we wait for more data because right now, there are some challenges, right? There's some false positives. If it's still positive, maybe it came down significantly and it's going to continue to. And so our understanding of ctDNA kinetics and how that relates to changing treatment, we're still not there yet. Probably in the future, we will learn that clearance is the best thing. And that some residual ctDNA, even if it has fallen, maybe is a reason to intensify, but we need to do those trials to really be able to look patients in the eye and say, look, if we intensify now, this is what it's going to get you, and these are going to be the benefits. So I think we still need to do those studies. I'll just share an anecdote from one of our early stage trials where we're looking at it. It's a tumor-informed assay, but we're looking at ctDNA over time, and we have a patient who, they had their lung cancer resected. They had an EGFR mutant lung cancer. They had adjuvant chemotherapy, didn't clear. They're on adjuvant osimertinib, didn't clear. It's 3 months now. There's still that low level positive, but this patient is still in remission. So, we have seen some nice data from ADAURA that suggests that maybe we should be a little bit more worried about this patient. But again, should we continue? What does it mean? Is it a germline variant? Did anybody bother to figure that out? There are a lot of unanswered questions still. And so I'm really looking forward to the next generation of trials that helps us figure out, what does a plasma test really mean? How should we really act on it and understand what the benefits are?
Yeah, and I couldn't agree more with that. We have studies open where we're monitoring patients every 3 months with their scans with ctDNA. And I think sometimes it brings up a lot of anxiety, right? 6 months in, your ctDNA is positive. 9 months in, it's negative. 12 months in, it's positive. What do you do with that? And it really depends on sort of the sensitivity of the assays that we're using. I agree with you. If someone has persistent ctDNA presence, after, definitive therapy, it would worry me. But if patients are clinically asymptomatic and the radiographs, the imaging are stable, really hard in 2025 to start or escalate to additional therapy. We don't have the data to really support that. And a lot of these assays that we use in practice, I think oftentimes will lead to a lot of stress, anxiety. It's the scanxiety. I'm sure you've seen that in your practice. That's enough already. And then we add upon that the anxiety, the molecular testing as well. And again, without having great data to support what to do with that result, I think it's controversial, but it's nice that we're building those data sets in our practice that may inform us into the future.
I agree. And thank you so much again, Dr. Sabari. So with all of that great data, we're going to conclude. And in particular, Dr. Sabari, I'm going to ask if you have any key recommendations or takeaways for the audience watching about what to do, how to select.
Yeah, so phenomenal discussion and always a pleasure doing these events with you. First off, going back to the basics, if you don't test, you won't identify these alterations. So all patients with stage 4 lung cancer need to have broad panel next generation sequencing, and not just because we're looking for EGFR, but we're looking for any or all actionable alterations, right? And I think today we focused in here on EGFR, but if you don't test, you won't identify these alterations. If you do identify an EGFR activating mutation in exon 19 del or L858R exon 21, I think there's a huge sort of explosion of opportunities for our patients. And, we talked about osimertinib alone. We talked about osimertinib plus chemotherapy, and we talked about amivantamab and lazertinib. My takeaway message is have the discussion with your patients about these regimens. I think, with the data that we have now in 2025, particularly the survival data for Mariposa, as well as the significant progression-free survival data for both Mariposa and osimertinib and chemo, it really behooves us to have those discussions with our patients. No longer is it acceptable to offer only single-agent osimertinib. I think after having the discussion about the benefits, as well as the risks and the side effects, as well as mitigation strategies, selecting the regimen, that's why we call ourselves physicians. It's an art. And, one regimen may not be the best for everybody. And I think that's really what I enjoy about my day-to-day job. I may have a patient who I talk to for an hour and a half about Mariposa, and they select osimertinib. That's the best therapy for them. And we had that discussion. I feel good about that. If someone selects, FLAURA2, I think having that discussion with that patient is critical. What are some of the standouts for me? We talked about CNS metastases being high risk. We talked about burden of disease, liver metastasis, bone metastasis, positive ctDNA, especially, sort of at time of clearance or 9 weeks not clearing. Those are high risk features. And I think as good as amivantamab and lazertinib are, as well as osimertinib and chemo, we need to continue to be thinking about the next generation of inhibitors here, because unfortunately we are still not curing patients with EGFR mutant lung cancer. So clinical trials are always great options in clinical practice. If you have them available in your community, in your sites, please consider enrolling a patient on a trial. Dr. Leo, what are some of your takeaways?
Thank you so much. I agree. I think it's great to have these new options. I think as oncologists, we need to work harder than ever to really make sure that our patients understand what's out there for them and really help them come to an informed decision. I think shared decision-making has never been more important. And I think that each patient will decide things, and it's really important for us to uphold their values. So for example, if somebody does have brain metastases, or I really feel they should have combination, but that's not for them, you really do need to support that decision. So I agree, these discussions, do need a little more time, but I think are very, very rewarding. I also like this concept of prophylaxis and this idea that we're going to be educating patients more and improving their journey. And also, the point you made early on, which is, Now we really need to be looking at the group for whom we don't need to escalate, and how do we de-escalate from these great studies, but then also pushing beyond and what comes next, and very thoughtful sequencing. Thank you so much.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, the International Association for the Study of Lung Cancer. This activity is supported by an educational grant from Johnson & Johnson. To access all materials for this activity, visit peerview.com/ZAF860.